Now, moving on to the other pathologies of the elbow, especially the fracture dislocation of the elbow. In this section, we'll be going through the pathophysiology and pathoanatomy of elbow dislocation, its classification and how a patient presents with an elbow dislocation, and how we can diagnose and what are the different imaging we need to do, especially in the case of elbow dislocation. Coming to the epidemiology of elbow dislocation, it is the most common major joint dislocation, second to the shoulder. Shoulder is most common, the second is elbow, because usually when we are falling, the first and foremost we are using our upper limb to hold on to something, and that is why when you, especially during falling, when we are trying to hold on to something, this results either in a shoulder or the elbow dislocation. It accounts for 10 to 25% injuries to the elbow. Posterior lateral is the most common type of dislocation, and that is almost 80% of the time. In 20% of the time, predominantly affects the patients with the age in 20 years of old, and other cases sometimes isolatedly posterior or it's posterior medial as well. And if you see, these are the red areas where there's more common, especially it's more traumatic, especially in the African countries, while in the Asian or European countries, this is less common as compared to these areas. Now coming to the mechanism of posterior lateral dislocation. As it is most common, and 80% of the time this results in the posterior lateral dislocation of the elbow, there is actually a combination of mechanism. When the patient is falling on outstretched hand, there will be axial loading, that is the bones will be pushed upward, supination, and there will be external rotation of the forearm. In that case, the load is actually mainly shifted towards the radial head and lateral part of the elbow, and with along the valgus posterior lateral force, this results in disruption of the lateral collateral ligaments and eventually leading to posterior lateral dislocation of the elbow. Although there could be a varus posterior medial mechanism as well, in which there is posterior medial dislocation, but usually that is highly rare. Posterior dislocation are also less common. Why? Because usually whenever there is a supination, there is always some degree of external rotation of the forearm, and the load is such that it is not very straight. It's always some degree of valgus producing force. It's very rarely that there is a straight force which produces a posterior dislocation. Now coming to the pathoanatomy, it may be associated with the complete or near complete circular disruption of the capsulus ligament stabilizer. As we know, around the elbow we have collateral ligaments on the medial side forming the medial collateral ligament, and we have collateral ligaments on the ulnar side forming the on the lateral side, that is the lateral collateral ligament. Among them, the most common and the most important is actually lateral ulnar collateral ligament, which it may result in cross instability and valgus instability of the elbow if that gets injured. Usually whenever this force is actually axial load is applied, the arm is in supination and external rotation, and valgus producing force acting on the elbow, this results in a progression of injury in from the lateral to the medial. That first the lateral collateral ligament fails, which is the primary region, by avulsion of the lateral epicondylar origin or through the mid-substantial and lateral collateral tears. But although the mid-substantial tear are less common, the first and foremost is the lateral collateral ligaments actually gets avulsed from the lateral epicondyle of the humerus. Then the force is transmitted posteriorly, eventually leading to the medial collateral side of the elbow, that is on the medial collateral ligament. Medial collateral ligament fails at the last depending upon the degree of injury. Sometimes it's only a lateral collateral ligament injury and the force is not that much. Once the lateral collateral ligament gives away, this results in posterior lateral dislocation and the medial collateral ligament is spared. But sometimes the force is so much that the force is acting on the lateral side of the elbow, then it goes posteriorly and eventually going towards the medial side of the elbow, and not only disrupting the lateral collateral ligament but also the medial collateral ligament as well. Now that is how we classify the elbow dislocation most of the time. There is an anatomic description. That is depending upon in which position it has dislocated. The most common it is the posterior lateral, sometimes only posterior and sometimes posterior medial as well. Other option is simple versus complex. What is simple versus complex? Simple is that it's a dislocation only. Ligaments have ruptured, the elbow is dislocated, and you can appreciate the dislocation. But sometimes the complex is that when the elbow was dislocating, it may be associated with the other fractures as well. There could be fractures of radial head, coronoid, olecranon, even the humerus as well. So when the associated fracture becomes complex, when simple dislocation is when there is only dislocation. As I told you, elbow dislocation with no associated fracture is simple dislocation, and it accounts for 50 to 60% of the elbow dislocation. Complex is associated with fractures. Now, the most common injury with elbow dislocation is called as terrible triad injury of the elbow. As it is a triad, there are three things associated with it. There is an elbow dislocation, which is associated with lateral ulnar-collateral tear, leading to radial head fracture and coronal tip fracture. So the most commonly the terrible triad include elbow dislocation, coronoid fracture, and radial head fracture as well. And when there will be dislocation, definitely there will be disruption of the ligaments, and most common the posterior lateral dislocation, the lateral ulnar collateral ligament. The other could be the varus posterior medial rotary instability. Now this is also one of the complex dislocation. This results in elbow injury associated with LCL tear and a coronoid fracture. Coronoid fracture is characteristics include medial facet fracture, and it's a comminuted only. In this kind of fracture, usually the radial head is spared, but this is associated with lateral collateral ligament injury, elbow dislocation, coronoid fractures. Coming to the presentation. Presentation of the patient, when the patient will come to ER, there will be pain and swelling. The pain will be so much that the patient will be having a decreased range of motion. On physical examination, we'll see the status of the skin needs to be evaluated. Sometimes there is direct force acting anterior to the elbow, which may result in a posterior lateral dislocation, and there may be associated open injury as well. We need to look at how much swelling is present and is there any developing compartment syndrome or not. We have to assess the neurovascular structure because the brachial artery is going through here, the radial, ulnar, and median nerve are also passing through this area, and we have to assess all these three nerves as well. And then plus the status of the wrist and shoulder. That is important. We have to see the patient as a whole. If the patient had an outstretched hand, not only the elbow will be affected, there may be a distal radius fracture, there may be associated acetabular fracture, or there may be something wrong as well. There may be a floating elbow if it's a very high energy trauma. There is a shaft of humerus fracture, radius ulnar fracture, along with the problems at the elbow joint as well. This is the imaging. The first and foremost is always the x-ray, and we have to get an x-ray of AP and lateral view of the elbow joint. This is showing the lateral view. If you see, there is a definite dislocation, and probably posterior fat pad sign is positive as well, so we may be having an occult radial head or coronary fracture as well. This is how the AP looks in, and if you see this overlap of the humerus over the ulna, so it is probably there is a posterior dislocation, and this is came out as this is the medial side. This is probably the posterior medial dislocation as well. This is how it sometimes it looks on the lateral view as well. Now this is, you see there's no posterior fat pad sign. This is a simple dislocation with no radial head, coronoid involved as well, but only posterior lateral dislocation of the elbow. In this section, we have briefly gone through the pathophysiology and pathoanatomy of the elbow dislocation. Elbow dislocation, the most common mechanism actually fall on the outstretched hand, and usually when the axial load is transmitted from the wrist joint to the elbow, with the elbow in the supination and externally rotated. When the valgus force is applied to the elbow, this results in the posterior lateral dislocation of the elbow. In classification, we have to look whether it is isolated, it's simple, that is associated with no fracture, or it's complex. When it's complex, it could be associated with terrible triad around the elbow, that is the radial head, coronary fracture, as well as the elbow dislocation. Or this could be associated with varus posterior medial complex injury, in which there is elbow dislocation along with the coronary fracture, but the radial head is spared. And we have to assess it as per ATLS guidelines. Once provided the patient is hemodynamically stable and is has been isolated injury, then we have to look at the patient, feel and move the arm. Along with, we have to get x-rays, especially the x-rays elbow joint, AP and lateral, to assess whether what type of dislocation it is, and then we'll move towards the treatment. Thank you very much. Keep watching sqadia.com.